Understanding the impact and consequences of chemotherapy in stage 4 pancreatic cancer. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been told they have stage 4 pancreatic cancer, you're in the right place. I know that when you hear stage 4, it can feel overwhelming and frightening. But today we're going to cut through the confusion and talk clearly about what chemotherapy options are actually available, what the research shows about their effectiveness, and what you can realistically expect. Stage 4 pancreatic cancer, also called metastatic pancreatic cancer, means the cancer has spread beyond the pancreas to other organs, most commonly the liver, lungs, or peritoneum, which is the lining of your abdomen. Most pancreatic cancers are actually diagnosed at this advanced stage. In fact, only 15 to 20% of people have potentially resectable disease at presentation. The goal of treatment at this stage is typically not cure, but extending life, managing symptoms, and maintaining quality of life for as long as possible. FOLFIRINOX is a 4-drug combination chemotherapy regimen. FOL stands for folinic acid, which is also called leucovorin. F is fluorouracil, also called 5. FU-irin is irinotecan, and OX is oxaliplatin. In a landmark randomized trial called PRODIGE, 4 patients treated with FOLFIRINOX had a median overall survival of 11.1 months compared to 6.8 months with gemcitabine alone. The 1-year survival rate was 48.4% with FOLFIRINOX versus 20.6% with gemcitabine alone. FOLFIRINOX is intensive. The regimen is typically given as modified FOLFIRINOX, which is a slightly less intensive version than the original trial protocol. Grade 3 to 4 side effects occurred more frequently with FOLFIRINOX and included neutropenia, which is low white blood cell counts, diarrhea, fatigue, and neuropathy, which is nerve damage causing numbness and tingling in your hands and feet. The treatment is given intravenously every 2 weeks, and managing side effects becomes a critical part of care. The second major option is gemcitabine combined with nanoparticle albumin-bound paclitaxel, which we call Nab-Paclitaxel or sometimes Abraxane. In the MPACT trial, which included 861 patients with previously untreated metastatic pancreatic cancer, this combination demonstrated clear benefits. Median overall survival was 8.5 months with gemcitabine plus Nab-Paclitaxel compared to 6.7 months with gemcitabine alone. The 1-year survival rate was 35% versus 22%. This regimen is administered at 1,000 mg per square meter of gemcitabine and 125 mg per square meter of Nab-Paclitaxel on days 1, 8, and 15 of a 28-day cycle. You're getting infusions 3 out of every 4 weeks. The main side effects include fatigue, neuropathy, low blood cell counts, and diarrhea. Gemcitabine plus Nab-Paclitaxel hasn't been directly compared with FOLFIRINOX in randomized trials, so choosing between them often depends on your individual circumstances. Not all pancreatic cancers are the same at the molecular level, and this can dramatically affect which treatment works best. All patients with metastatic pancreatic cancer should have both germline testing and somatic tumor testing. About 4 to 7% of pancreatic cancers have pathogenic variants in genes called BRCA1, BRCA2, or PALB2. If your cancer has one of these mutations, platinum-based chemotherapy like FOLFIRINOX may be particularly effective. About 1 to 2% of pancreatic cancers have a specific KRAS G12C mutation. While these patients still receive standard chemotherapy initially if the cancer progresses, there are now targeted drugs called KRAS inhibitors, specifically adagrasib and sotorasib, that can be used. In clinical trials, these drugs showed objective response rates of around 30 to 50% in KRAS G12C mutated pancreatic cancers that had progressed on prior therapy. For patients who initially received FOLFIRINOX and then progressed, gemcitabine plus Nab-Paclitaxel is an effective second-line option. In retrospective studies of 427 patients with advanced pancreatic cancer previously treated with FOLFIRINOX who then received gemcitabine plus Nab-Paclitaxel, the combination showed a median progression-free survival of 3.5 months and median overall survival of 7.1 months. For patients who started with gemcitabine plus Nab-Paclitaxel, second-line options include FOLFIRI or fluorouracil plus leucovorin combined with liposomal irinotecan. The liposomal irinotecan combination was studied in the NAPOLI-1 trial. Patients receiving this combination had a median overall survival of 6.1 months compared to 4.2 months, with fluorouracil and leucovorin alone. If you can't tolerate intensive combination chemotherapy due to poor performance status or significant comorbidities, single-agent gemcitabine remains an option. It's less toxic than combination regimens and can provide meaningful symptom relief. In pivotal trials, gemcitabine improved clinical outcomes, including pain control and performance status, compared to fluorouracil alone, even though the survival benefit was modest, median survival of 5.7 months versus 4.4 months. Not everyone is a candidate for aggressive multi-drug chemotherapy. If you already have significant weight loss, are unable to carry out basic daily activities, or have other serious medical conditions, your oncologist may recommend single-agent therapy or even best supportive care focused on symptom management. This isn't giving up. It's about matching treatment intensity to what your body can actually handle while maintaining the best possible quality of life. The ECOG scale is commonly referred to when describing the ability to perform tasks. Please pause and review the image to understand. Ask specifically, has my tumor been tested for genetic mutations including BRCA1, BRCA2, PALB2, and KRASG12C? If not, request comprehensive genetic testing, including both germline and somatic tumor testing. This isn't optional. It's essential for guiding treatment decisions. Ask, what is my performance status and how does that affect which chemotherapy regimen you're recommending? The Eastern Cooperative Oncology Group Performance Status, or ECOG scale, ranges from 0 to 4. A score of 0 or 1 means you're fairly active and suitable for intensive regimens like FOLFIRINOX. A score of 2 means you're limited, but can still care for yourself at this level. Gemcitabine plus Nab-Paclitaxel might be preferred. Scores of 3 or 4 suggest that intensive chemotherapy may cause more harm than benefit. Ask, what are the specific side effects I should watch for, and what's the plan for managing them? Get concrete answers about neutropenia management, whether you'll need growth factor support anti-nausea medications, and how to recognize signs of infection or dangerous diarrhea that requires immediate medical attention. If you have BRCA1/2 or PALB2 mutations and respond to platinum chemotherapy, ask, should we be considering PARP inhibitor maintenance therapy? There's emerging evidence that drugs like olaparib may help maintain remission in patients with these specific mutations who've responded to platinum-based treatment. Early palliative care involvement is not about end-of-life care. It's about managing symptoms and maintaining quality of life from diagnosis onward. Research clearly shows that patients with pancreatic cancer who receive early palliative care consultation have better symptom control, fewer emergency department visits, less chemotherapy use near death, and may actually live longer. You should request palliative care consultation at diagnosis or very soon after. It is important to initiate contact with palliative care at diagnosis and follow advice. Specific indicators include uncontrolled pain, despite opioid medications, significant weight loss, or difficulty eating, depression or anxiety that's affecting your daily functioning, or jaundice requiring biliary stent placement. If opioid medications aren't providing adequate relief, ask your oncologist about celiac plexus neurolysis. This is a specialized nerve block procedure that can provide significantly better pain control for pancreatic cancer pain than medications alone. Research shows it provides better pain relief, reduces opioid consumption, and improves quality of life when performed early, rather than waiting until pain becomes unmanageable. Organize your medical records and create a medication list. When dealing with complex chemotherapy regimens, you'll be seeing multiple specialists. Having everything organized prevents dangerous drug interactions and ensures everyone knows your complete medical picture. Establish a support system. If you're the patient, identify family members or friends who can attend oncology appointments with you. Research shows that having someone present helps with information retention and decision-making. Address practical concerns immediately. This might include discussing advanced care planning, ensuring financial and legal documents are in order, and connecting with social work resources. This isn't being pessimistic, it's being prepared and reducing future stress. Recognize warning signs that require immediate medical attention. Fever over 100.4 degrees Fahrenheit while on chemotherapy, severe diarrhea or vomiting, lasting more than 24 hours, severe abdominal pain. Black tarry stools, suggesting bleeding, sudden onset of leg swelling or chest pain, which could indicate blood clots, or yellowing skin and eyes, suggesting biliary obstruction. Stage 4 pancreatic cancer is serious, but modern chemotherapy offers real options that can extend life and maintain quality of life. Your next step, schedule a comprehensive discussion with your oncologist about genetic testing and which treatment regimen matches your individual situation. This information is for education. Always discuss your individual situation with your healthcare provider. I have outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.